Okay, well, thank you very much for joining us today. It's a great pleasure to have you with us, and thank you for making it down to Denmark Hill. I think we're in for a really exciting day today in this our first AI CogStack and genomic AI network PPI AI showcase. All right, bit of a mouthful, but so yeah, my name is Richard Dobson, and I'm a co-founder of CogStack along with Tom Searle and James Teo, also a professor of medical informatics at King's and also at UCL as well. And I split my time across the two. So just a bit of background on CogStack, the project, and you know, kind of why we're here today. I guess this all kind of started off in around about 2015, 2014, with Anwar and King's College Hospital, because of the program Genomics England. So Genomics England and the hospitals taking part in the program had this task of recruiting patients into rare disorders programs or cancer programs. And it was really challenging to do this because a lot of the information within the hospital record that they needed in order to be able to identify people that fitted criteria for recruitment and to subsequently populate the phenotype models that were required for recruitment, it was really difficult to find that information. That information was locked away essentially in the hospital systems, in various different kind of systems or files or records. Very little of it was structured. So there was this massive problem, right? So we kind of worked out or formed a collaboration with King's College Hospital. This was the informatics team at King's College London, in order to be able to see, whether we could do something to help this and help this problem, because hospitals had to recruit, but they just couldn't. So Genomics England was under recruiting. So the first thing we did was we started pulling all of the data together. We developed pipelines in order to be able to suck all the data out of different places and put it into one big data lake, making it available, essentially just making it available for search. So somebody could then search a patient, look through their records, as they would do in the olden days if they were flicking through paper. They could now search in a Google-like way across the record system. This information had been unlocked. But that was just search. The next challenge was to be able to convert this information, this vast amount of information which was locked away in the record, into more structured representations of the data. Okay, so then we were kind of going from the equivalent of, you know, like a Word document narrative to something that looked a little bit more like an Excel sheet with structured information for each patient. So that helped us find them through search and then populate the phenotype models through more complicated semantically aware search and subsequent recruitment. So that was great. And that was recognized early on as being really important by people such as the Chief Medical Officer, who highlighted this work within her report in 2016 on the called Generation Genome. And this was key enabling technology she recognized in order to be able to recruit. But not just to be able to recruit, to be able to generally unlock all this information within the system. And so following this, it began this 10-year journey up to now of work within and on information within electronic health record systems. So prior to the initiation of CogStack, we'd had a program called CHRIS at the Maudsley, which started in 2007, which kind of really set the seed for text work, but also the governance models. The critical thing about that program was how we manage the governance around access to data and access to data for research primarily. But anyway, we had this program starting in 2014-15, CogStack, which went through, has evolved and had many kind of milestone moments along the way. First publications, scaling to different hospitals, new kind of language approaches coming into play, our ability to kind of take advantage of the advances within language modeling that everybody will have become aware of in the past couple of years, and really kind of developing out in a number of ways, all of which were kind of based on this fundamental capability to be able to deep phenotype whole hospitals, all the data within hospitals, to be able to characterize and capture that vast amount of information which was otherwise locked away below the surface, the lower part of that iceberg, which kind of represents plus 80% of the information within a healthcare system. So this kind of, as I say, kind of unlocked many applications, many opportunities, which included internal use cases, so around clinical coding, for example, so routine hospital functions, around finding people for trials, around populating local registries for research programs, as well as business and operational users, and more recently, well, early days of kind of language modeling, using or developing kind of smaller type language models through to more recent larger language models. So these serve a function within the hospital, but also we can start to populate or feed into requirements of external data consumers and partners, providing the structured information derived from the unstructured information for many different stakeholders. And so a lot of this you'll hear about through the various talks today, this morning and this afternoon. Just to focus on one area, so shifting to the right of that timeline has been the more experimental work, still very much in the research domain, on large language modeling type approaches or generative AI type approaches, and using these as general forecasting models. So these approaches are called large language models, but they're essentially kind of temporal sequence modelers and predictors. And so what we did at King's College Hospital again and South London and the Maudsley was all of this deep phenotyping information that we'd created by structuring the record. We took this information and fed it into one of these large language model type architectures, a transformer-based architecture. And we ordered the SNOMED codes in this case in time, and then fed those in, and then trained a model to be able to kind of suggest what was going to be the next medication or the next symptom, the next disorder, or the next diagnosis for a particular patient given their historical timeline. And we could predict the next thing, or we could predict multiple steps into the future. And this has been very useful and very interesting for a number of use cases, including kind of modeling counterfactual scenarios, emulating trials, as well as educational purposes, and really kind of understanding bias and fairness within the systems, understanding practices within the healthcare system, within the hospital, because whatever the model had learned, it would suggest, and what it's learned is based on real world practice. And so this has led to a partnership with regulators. In this instance, we kind of partnered with DCIT, the ICO, the Equality Commission, and Innovate UK on running the Fairness Innovation Challenge, which was a challenge set up this year to explore socio-technical solutions to issues of fairness and bias in AI. And more recently, it's led us on to kind of scale this model up to national level. We're working with the NHS England, HDR UK, BHF Data Science, and AWS and Databricks in order to take that model. And we're now training it on and have done the first round of training on 57 million people in the national secure data environment. So anyway, this essentially has led to, I think, a platform which is deeply flexible, developed within the NHS, for the NHS, but also for any kind of healthcare provider. And we feel like there's a great opportunity for this now, and I think it's become accepted as part of NHS kind of foundational capability. And being recognised in a number of different ways, and some of that you'll hear about today. So just to move on now, after that little bit, tell you a little bit about today, and then we'll move on to the first session. So first of all, we're going to be having a session based on AI, clinical NLP, and engineering for healthcare informatics. And that'll focus on how there'll be a discussion around how we extract valuable information from the unstructured record, and also looking at AI and machine learning approaches in genomics research and how tools for clinical data management can have a significant impact on real-world applications. Then we'll have an industry roundtable where we'll be discussing with various industry leaders about how they're using AI to improve clinical research and patient outcomes and the kind of challenges that they face. And then we'll move on to a session this afternoon on AI in medicine, where we'll have a number of researchers talking about various technologies and applications of AI to support clinicians and improve patient outcomes. And this will be covering exemplars, use cases in a range of different specialties. And then we'll finish off with a PPI, patient and public involvement and engagement session, where we have various leaders of patient groups discussing the potential of actively involving and the importance of actively involving patients and public within clinical research, and also think about effective implementation strategies and the impact of quality, research quality and patient outcomes.
Hi, everyone. So great to be here today. Good to see so many familiar faces and not so familiar faces. Hopefully we can be friends later on. I'm here to provide a session overview first. I'll then go into a little bit more detail about actually the reasoning why CogStack as a series of technologies exists. If it wasn't motivating enough, hearing what Richard was saying about all the data issues healthcare has. But I'm a PhD in clinical informatics, clinical NLP. So I'm not a clinician by training, but I've spent a fair amount of time surrounded by them. I'm CEO and co-founder of CogStack Limited. This is the commercial entity that's really responsible for taking CogStack and a series of technologies and research outputs to market, and trying to get it in the hands of folks that can really best use it. I'm also a clinical informatics researcher still at KCL as well. So agenda for this session, again, I'll be providing an overview, talk about some NHS data, the whys and whats of CogStack. Will then be followed by Kawsar, a research fellow at postdoctoral researcher at UCL, UCLH, on the engineering challenges of deploying some of this technology and perfecting it across the UCL, UCLH system and various kind of AI challenges he's encountered there. Vishnu on remotely will be presenting developments from East Lancs and building out the secure data environment, the SDE, there as well. In particular talking about modern infrastructure. And it's really interesting because he's a surgeon by training as well, and how he's built infrastructure to improve data science and AI capabilities, both for his teaching hospital as well as the SDE that he's building. Srikanth and Richard Bear will be presenting from Monash, so it's quite late for them, but they'll be presenting outputs of using CogStack technology to be able to impact kind of dementia research and how EHRs can be used to improve patient outcomes, in particularly for improving healthy aging. Zena, who I've just seen from KCL, will be presenting, finally closing us out in building kind of fairer artificial intelligence systems for electronic health record analysis. So I guess bring it back down to why we will here, why does all this technology exist? And it all kind of boils down to search. And why is search in health data so difficult compared to a little company that was started 26 years ago, I looked up yesterday, called Google. That's essentially their mission was to organize the world's information. And they pretty much achieved that mission. They've got a printing machine that now prints money for them because they've solved search for everyone. So we all use Google pretty much on a day-to-day basis. But then why is it so hard to search across electronic health record system, or EHRs, within a hospital when Google has kind of solved it for the world's information that's openly available, open domain information? Well, it's hard because there's, in the secondary care setting, there's a lot of information that's passed between your GP and your doctor, but often you might attend a clinic, a referral, to go to hospital, and they know your name, they maybe know the reason why you're there, hopefully they do, but they maybe don't know any other historical information from you, so they just ask you, right? Any clinicians in the room, you've probably taken a history before, and you've asked them, why you're there, what's the context of your whole experience, and all that data that the clinician collects and inputs. A lot of the time, clinicians get really disenfranchised with these systems because they don't see any value from them entering in detail all this data. So then that kind of provides a loop of just the data being really stale, being really incomplete, being really old. And that really does perpetuate the problem. I think secondary to that, healthcare data, this is a King's College Hospital old estate picture of all the different systems that were used within KCH. And that's just one hospital trust in the UK. There's 220 of these. They've each have their own budgets, their own systems in place to be able to procure and provide systems that provide digital capability. There's also a mix of live and archive data. So often web scale data, if you look at a 10-year-old kind of website, no one really looks at a 10-year-old website anymore. They often look at websites that are produced in the last couple of years because you can kind of tell by the dodgy CSS that you see. Whereas if you have archive data in the health record, patient comes in 5 years later, that 5-year-old data can be just as valuable because it contains all that historical data, but it's stored in these 6 other systems that you need to process, ingest, and make available. Really perpetuating that search argument, why it's so hard. There's also inconsistent use of an adoption of standards. So in the internet, the open systems interconnected model, there's protocols which specify how data is processed, how it's presented, and those standards are really adopted at scale by everyone. So those standards really help when you're trying to integrate data into one kind of search index, as Google has done. Really tricky here. And that's just at one hospital as well, right? Data is also multimodal. So an MRI or a CT or an X-ray is a fairly large piece of data that you store per patient. And I recently got hit by a car, funny enough, on a bike. And I had, I think, 4 different X-rays at the time. I had 2 follow-up X-rays. That's a serious amount of data that actually needs to be stored about just that one issue that happened. I was also hit by a Deliveroo guy 2 years ago. It's a theme. Yeah, I should probably bike it a bit more safely. But regardless, I had another X-ray then as well. And I broke my arm. And all that data is stored just about me, compared to all the other kind of MRI, CT scans that happen for patients that are maybe a little bit older, are fairly sick, and go in and out of hospitals. There's serious difficulties in just getting this data organized and searchable just within a single hospital environment. So outside of the single hospital environment, Zhou Zhang, who's presenting and kind of chairing our industry panel later, and Jess Morley, who's actually presenting from Yale later as well, they've mapped out all the health data flows from healthcare data producers. So these are the primary and secondary care side of things. So this portion of the lower hand, right-hand side image. And then you have data extractors. So these are the commissioners or the integrated care systems, shared care records. This is where data is kind of aggregated into one place and then collected for better use, ideally. Then you have the data consumers. These are folks of life sciences folks, UK Biobank in there, the clinical practice research data link is in there. This introduces a serious amount of complexity in actually getting all this data available and not duplicated, not repeated in certain places, not erroneous in others. So you can see the kind of scale in which that this problem is really hard, and data from one single GP practice should ideally flow all the way up to all these data consumers. And that's a really hard, tricky problem that they actually published about in Lancet DH. Okay, but zooming in on actually the data itself, Richard already alluded to the fact that we have 80% of our healthcare data is unstructured. So this is the clinical narrative that clinicians type into a care record when they're looking after you. And that, in their own words, is the patient experience, right? So it's what you said to the clinician, it's what their interpretation of what you said to them, it's their interpretation of a scan or an observation that they're doing about how you're doing and how you're feeling, what disorder you're presenting with. Having all that data in an unstructured form, it's really hard to process again if you want to really make some decisions around it. So you really need it in the structured representation. Having it in this unstructured form is costly right across the kind of value chain of folks that deliver healthcare. So you've got clinicians that can't get the full value of medical records because they can't find what has previously happened to a patient, or if they want to aggregate patient data together, if they're doing an audit, any junior doctors or any other clinicians actually in the room have probably done an audit where they've manually gone through probably thousands of pages of notes. Operations teams can't standardize and kind of build better processes because they just have a sea of unstructured data that they just have to manually read through and probably note down in an Excel spreadsheet like everyone else. Finance teams are also losing revenue. So when care is billed, finance teams have to actually read through sets of notes and then appropriately define whether a thing was, a procedure or disorder happened to that particular patient. And often it's them just reading through reams and reams of notes. So what does CogStack do at this basic level? It really makes data searchable. So we ingest all forms of text data, whether that's PDFs, Word documents, EHR, proprietary formats, imaging reports, and any other kind of clinical systems which we can ingest structured data as well. It really harmonizes all that data and makes it searchable. There's also a live and historical aspect to it as well. So we're really agnostic to any kind of EHR system provider. And that's really helpful because it means we can really faithfully go into any conversation with any provider, any healthcare provider, and say, they say, oh, well, we've got this custom built system that we built over a couple of years, and we procure this other thing and attach to it. Will it work? And we can faithfully say, yes, we can make it work. We can work it out in partnership with you. So what does that really mean once you've kind of extracted the data from the source data system, that transformed it into this harmonized form and then loaded it into a place where you can make it searchable? Well, you get, at a basic level, this kind of screen on the right. So I've searched for diabetes in this publicly available de-identified data set from the US, and it returns, I think, 100,000 results. And the thing in here, you can't see it's too small, that there's diabetes results of patients that have a history of gestational diabetes or no presence of diabetes within their record because their HbA1c was fine, or if there was suspected diabetes because their HbA1c suggested they have, but it's not confirmed. All that stuff is fine because now the data is searchable, but there's no context within that data, right? So we've all probably used ChatGPT. You can talk to it and it understands context to a degree, it understands negations, it understands history of mentions, so like the temporality features of a given concept or a given idea. So we can do the same thing with health data as well. We can train language models to be able to recognize the context of the data. We can get it to recognize acronyms, synonyms, all these various ways a clinician loves to talk about a given disorder, symptom, finding, medication, procedure. Sorry, I say this a lot. And what this really does is this provides structure at scale. So we can structure that mass 80% of healthcare data within that single trust environment, and then essentially create a pretty Excel-like table that suggests whether there is presence of a given condition or whether it happened in the past or otherwise. So this produces en masse a massive amount of data. So from just this data set of this ICU data set from the US, there was around 300,000 notes, and this produced 172 million annotations with all that context kind of provided in there as well. So we can scroll through here and then we can pick out all the diabetes terms. Again, it's pretty quick to respond. We can search diabetes. It gives 100,000 results or something, or 264,000 results. So not that useful for actually want to use it really at hand, but this example of the stack, let's not focus on that too much. So really, the main thing to note is that these platforms, this blue bar at the bottom, are the platforms and pipelines that perform this extraction at scale, the loading at scale, and then this application of clinical language AI at scale. This allows us to build systems and applications on top in partnership with our NHS Trust friends, partners, and we can build out things like dashboards that show admissions over time, that show deaths per year, that show medications that a single patient has taken over time, because we can drill down into this data set live because it has all this structure available from this unstructured data. We can build a cohorting system. So if we want to search for all the patients that have a given diagnosis of diabetes, so diabetes, and all the complications and secondary conditions, so type 1, type 2, and any other complications, diabetic retinopathy, etc., then we can do that because all that structure has been applied on top of that unstructured data. We can also help finance teams be able to improve processes by pulling out all that structure again, aggregating it by an episodic view. So patient comes in for as an inpatient, they have an episode of care, then they get hopefully discharged, happy and healthy. That needs to be costed up by the finance teams by suggesting what their primary diagnosis was and primary procedure that they received. All of that can be assisted by this natural language processing AI technology, as you can see on this screen. So in summary, CogStack is founded and owned by a series of NHS trusts, King's Health Partners trusts, and University College London hospitals, as well as KCL and UCL. We spun out now, 2024, and we're in operation in the UK, Europe, Asia, and Australia. And now I think I'll pass over to Kawsar, who will be taking us through our next session.
Okay, thanks everyone. Thanks, Tom. So I'll be talking today about the deployment of CogStack at UCLH, in particular trying to give you a flavour of what's involved in deploying the stack, as well as going through some use cases, so looking at how CogStack has been used at UCLH. I'm going to try not to repeat stuff that Tom's already said, just in the interest of time. At UCLH, up until recently, we've been a reasonably small team comprised of myself, who's a full-time resource, a part-time resource, Chi. We're managed by Richard Dobson as well. They can't do the slides.
They should be able to.
Yes, thank you.
Yes, continue. So what I'll do today, I'll talk about the deployment in terms of two things. I'll talk about the actual deployment, then I'll talk about the projects that we've supported as through that deployment. In terms of the environment we're working in, we have access to two VMs. At the moment, we're CPU only, but recently we've been having some luck with an Azure collaboration, which means that we have access to GPU on demand when necessary. Okay, so this diagram here kind of describes at a high level what our deployment looks like. On the left-hand side, you're looking at the data ingestion part, which involves hoovering in data from the live hospital record, as well as the archives data store. That makes its way into our data lake, which is comprised of a number of databases. The most important one of which is Elasticsearch, which Tom kind of alluded to in his presentation. We also sometimes structure the data as it's coming in. Then once it's in that lake, we then have a series of NLP technologies which can interact and interrogate that data, structuring it and putting it back into the record, making it available for search or downstream applications. What you're seeing on the right-hand side is the typical type of user, that clinical user that approaches CogStack for collaboration. Either they need governance, either there's a governance requirement to de-identify the data, which means that we have to redact names, addresses, anything that's sensitive to the patient, in which case we have a model called AnonCat, which can delete these names, it can detect and redact those names. If not, then we have another workflow for letting patients access that data. Cool, so I'll talk about the ingestion process at UCLH. So in terms of live data, from April 2019, UCLH moved to Epic as a vendor for its EHR systems, which meant that we have CogStack had to develop live connections into the Epic record. Through those connections, we're able to ingest clinical notes, imaging reports, letters, lab reports, and other structured items such as demographic data, which is useful for that cohorting app that Tom demonstrated. All of the infrastructure is hosted inside of UCLH, so there's no data leakage sort of risk involved in that. Other sort of resources that we're tapping into, we're looking at everything that's pre-April 2019, so pre-Epic is stored in an archived data store. All of this data is in either a PDF or a Word document, which isn't immediately ingestible into the data lake. And so we're using an OCR technology. That's I forgot what the acronym stands for right now, but it basically pulls out the text from the documents, then pushes it into the data lake. So for that purposes, we're using Apache Tika. I think there's been an issue with the slides, but we're also connected to working on connections with data that's coming from outside of Epic. So things, for example, GPs sending letters into the hospital is stored in a separate database called OnBase, and we're building connections with that. And we've also got a sort of a drag and drop functionality as well, which means you can drag and drop your own data sets into the platform to be analyzed as well. Okay, this is sort of I think a slightly older tally. I think there's been an issue with the slides, but we're looking at roughly about, I think, 45 to 50 million records that we've ingested so far. And this is just looking only at the notes, imaging reports, and letters, which are the biggest data sets that we've got coming in to the data lake. Cool. So I'll talk about the interesting stuff now, which is the NLP stack we've got deployed at UCLH. So this is kind of zooming into that NLP box that we had in the first diagram. What we have is a bunch of core popular models that are hosted inside their own containers, can be interacted with, and these containers are running on a daily basis and pulling in data from the lake and pushing back the annotations or the structured bits back into the lake. The models that are most oft requested are the de-identification model, because it's often the case that that clinicians need redacted data very quickly. So we have the workflow constantly de-identifying the record on a daily basis, so it's available on demand. More recently, we've had the space now to annotate the record on demand as well. So we have storage space to now annotate everything and have it ready and available for clinicians to use. That's probably about 3 weeks ago. So those models sit inside their own containers. We can track the provenance or the lineage of the models using some technology called MLflow, which allows us to see the version of the model, if it was retrained, what data set was used to retrain it, lineage of the model, so you can keep track of the performance over time. In case a clinician finds that the model hasn't performed as expected, or they want to fine-tune and tweak the model, we have a number of annotation tools that can be used to spot check or fine-tune that model. Tom demoed the MedCat trainer, which is specific for the MedCat model, and we've also got some other interfaces available to fine-tune non-MedCat models. All of this, we have some other APIs set up, sort of gateway APIs that we can use to trigger these annotations or to pull data from these tools into the data lake. When clinicians are annotating these data sets, we're creating like a bank of annotations which we're storing in a separate database. So these can be used to retrain the models on scale afterwards as well. So this is kind of a view of what one of the popular models called MedCat, and what MedCat can do is it can, if you give it a piece of clinical text, it will pull out SNOMED concepts or ICD-10 concepts whilst you're typing it. It also gives you some metadata as well, so it will know if a concept has been negated, if it's related to the patient or a family member, and other such meta items. So this model that we're looking at here was a model that was trained across a number of sites, KCH, SLAM, and UCLH, and I think GSTT as well. And so through our data sharing agreements, we're able to share these models and make use of data across a network of hospitals, not just one, which means ultimately at least a better performance in the long run. For the sort of non-MedCat cases where we're having very bespoke sort of custom models required, we've built a wrapper around a very popular library called Transformers. And if anyone's in the Python space, in the NLP space, that have heard of this library. So we have the ability to train anything that's hosted on a Hugging Face effectively, and that can be plugged into our ecosystem when necessary. And so you can do things like multi-class classification, NER, multi-label classification, all of those things. And more recently, we've been experimenting with LLM sort of prompting type models as well through a couple of PhD projects. So this is a quick look at the UI tools that I spoke about, which are used to train the model. Tom's already talked about the MedCat trainer interface. And one thing that Tom didn't mention is that as you're annotating a document and submitting it, the Medcat model is being fine-tuned after each submission, and that's possible because of the Medcat architecture. For other model, that's not possible. You have to train everything from scratch once you've annotated the entire set, and so you can't have this sort of active learning type loop for every model, but that's possible for Medcat. So this is the interface for the Medcat workflow. In terms of model hosting, each of them sits, this is like a technical detail for those who are interested, sits in their own Docker container. We can spin up as many models as we want. We can switch them on and off in accordance to how much compute we have, or whatever compute constraints we're looking at as well. Cool. I'll talk briefly about the user experience. So when a clinician comes or a collaborator comes, what are they looking at when they're working with us? We have a type of launchpad gateway to the app, so people can sign up, log in, and once they've logged in, they have access to a range of services. So on the top, you're seeing the UIs for training the models. You have a couple of applications for interacting with the data. Tom showed the Elasticsearch Kibana interface. We have systems for extracting data. So if you have a cohort you're interested in and you want just the text for that, we have a catalog app. We have a couple of dashboards as well, which have been custom built, which I'll talk about in a bit. Since Tom's already gone through the cohorting and the search application, I want to. Okay, and this is supposed to be a video, but this is the catalog app used for which clinicians can use to pull data out of the system. So in the first page, they can go in there, they can specify a cohort via various filters. Once they send that, someone on the CogStack team can approve the request based on their submission. We can review governance and see if their request satisfies the governance. Once we press accept, we then there's an automated process which goes into the data lake, pulls that data, and makes it available for download for the user. And all of this, of course, is hosted in the UCLH network, so there's no risk of data leakage. And this has been quite useful for sort of small research projects where people want data quite quickly and don't want to have to go through the process of search. So over the next few slides, I'll look at some downstream applications of CogStack and use cases. The first relates to the app that I just talked about in the previous slide. And this is a collaboration we're doing with the OMOP extraction service team. So OMOP, for those who don't know, is a data standard which structures the data extract and allows for basically just formats the data in a way that other sites can use as well quickly. There's another team at UCLH which have developed a system for providing structured OMOP extracts. And the way it works is that the user approaches the team, they provide a cohort specification. That data then makes its way through this R package called OMOPS, and then the system interacts with the hospital record and spits out a structured data extract in the OMOP format. Recently, we've been collaborating with this team to enrich this extract with NLP concepts, which involves pushing annotations from the CogStack data lake into the note and note NLP tables in OMOP, for those who are familiar with that. This is another application that kind of sits on top of the hosted NLP models. It's called MyAid, and the idea here, this sits in front of a clinician on the shop floor as part of the live hospital. And as the clinician is typing their note, they have the option of sending that note to the hosted NLP models by CogStack, and CogStack will send back various annotations it's found inside that note. So things like allergies, medications, and the problem list. And the clinician can then accept and reject and push that on permanently onto the patient's record. Previously, prior to this was a manual process, so the clinician will have to add those things manually. Now this is auto-populating that record for them, improving the speed of reducing the admin burden from the clinician. Tom's already talked about this, but we've also got a coding co-pilot type UI at UCLH. This video's not working. But essentially, it's an app which the coder can use to have sort of an AI assistant suggesting codes that need to be added to the patient's record based on what's in the free text note. We've also collaborated quite strongly with the Queen Square Neurology Clinic to solve some low-hanging fruit type problems. One of which was clinical trials linkage project that they were doing manually previously. So previously they had like a senior nurse or senior member of staff manually going through the notes for the patient and going onto the Clinical Trials Gov website to figure out what was relevant for that patient based on the contents of the note. We've automated this now by having CogStack sit in the middle and pull out the concepts, send it over programmatically to the Clinical Trials Gov API, and then push the linked trials to the patient. And so we've built a dashboard around that. Unfortunately, the videos aren't working. Okay. Had you seen the video, there would have been a dashboard with the trials linked in. This is another big project we're doing with the GI clinic, which looks at the loss to follow-up problem. So this is a very simplified diagram describing how healthcare works. You have a clinician who sees a patient, and after seeing the patient, they have two responsibilities. The first of which is writing up a summary of what they discussed with the patient, and the second is creating any orders or follow-up actions in the system. So things like requesting imaging procedures, discharge orders, referral orders, and once the patient follows up with that action, the process repeats itself until the patient is discharged ultimately. In many cases, the clinician will forget to create the orders, but they would have noted their intent to create the order in the system. So they would say something like, patient needs to be referred to said specialist, I will create the order. They don't create the order, but they've mentioned it in the note. And so this, if the order goes missing, it means that the patient ends up in sort of like a limbo state. They haven't got anything to do. And so they end up, if enough time elapses, they end up lost to follow-up. So what we've developed is an NLP model which sits in between that step, and it's constantly scanning the notes to figure out if the clinician has intended to do anything, and if it's intended to do something, we make a check against the hospital record to see if that order was created or not. If there's a disparity, we can raise an alert with the operational staff. This is kind of a table describing the performance of the model so far. So we're detecting a number of categories of intents. So things like discharge, referring to dietitians, adding to the surgical waitlist, request for bloods, imaging procedures, etc. The performance is reasonably high. We have this workflow that we've set up at UCLH. I'm not going to go over it, but it's basically what I've described. We have the models constantly scanning over the notes, looking if the clinician's detected something. If something's been detected, we're making a check against the hospital record to see if the order's been created. If there's a disparity, we can then raise an alert with the clinical operational team to investigate. Again, for some reason, the videos aren't working, but you would have seen that dashboard live there. That's it, actually. So I've just finished. Yeah, thank you so much.
Thank you. Morning all. Tom and Richard and James, thank you very much for having me. I think between Tom and Kawsar, they've kind of covered about 2/3 of my presentation, so I'm not sure what I'm going to talk about. So I'm like Tom alluded to, I'm a consultant surgeon at Lancashire teaching hospitals. That's about 25% of my role, and for the remainder of the 75%, I primarily, I think the best way to describe my role is as platform engineering lead. So I lead a fairly diverse team of infrastructure engineers, data engineers, research and governance specialists, and public engagement specialists on a wide-scale digital transformation program across Lancashire and South Cumbria. Let's see if I can move these slides along. So Lancashire Teaching Hospitals, we are a major trauma center. We have 2 hospital sites, very similar digital in a landscape as to what both Richard and Tom spoke about. We've kind of digital maturity has evolved over the past 15 years or thereabouts. which then means that you have a variety of different clinical applications that are being brought in for bespoke purposes. We do have a EPR, but we also have multiple bespoke systems. We have 5 providers like us in the region within the ICB. There are 4 acute providers and a mental health trust. We serve a population of 1.8 million. We have over 250 GP practices. We have some of the most deprived areas, neighborhoods in the country. We also have some of the more affluent regions. So health inequality is a major issue. But today I'm hoping to cover a few things. My slide says current state. When I speak of current state, I'm really talking about what things look like in April 2020, when I started at Lancashire Hospitals, and what we've done over the past just over 4 years. If anyone's into video gaming, you will recognize the background there. The Witcher, when you pick it, I'll tell you why that's so relevant. In my last slide. So this you'll all be familiar with. As with any healthcare system, we have a huge amount of structured data. We also have a whole pile of unstructured data. And the vision was quite simple. Can we pull all of this data together, put it into a single region scale data lake, where we started off with data warehouse and then it became a data lake, and now it's called a lake house. But you get the idea. You put all of it in one place, and once you've done that, you can use that for near real-time direct care or operational intelligence, population health management, etc. But you extend that by putting in something called a trusted research environment alongside it, which then allows you to provide curated, anonymized, and minimized data sets for external researchers to do all of the cool stuff that Kawsar and Tom were talking about earlier. How difficult can it be? That's just my hospital. So imagine a patient comes in. I think people have heard this talk previously. You'll know exactly what I'm going to say. Patient comes in. Their referral data sits in the EPR. They get a colonoscopy. That goes into a different system for us. Radiology reports and images sits in our PACS system. They get discussed at the MDT. We use Somerset Cancer Registry, which again is a web application, I believe, backed by a SQL Server database. Our operation notes go elsewhere. Chemotherapy is a regionally hosted, cloud-hosted system with a vendor-managed database. And the patient goes home, and we don't know what happens to the patient after that because the data sits in primary care, and we don't have access to primary care data just yet. And to make things more difficult, all of these systems are backed by different technologies. Our EPR is data warehouse is in Oracle. We have SQL Server. Our laboratory system uses Sybase, and it's actually in German, so the tables and columns are named in German. That's just one healthcare organization. And I think Richard said there are 220, or Tom said there are 220 trusts around the country. You have the same problem everywhere. Not just with unstructured data, but also with structured data. It's difficult enough to get value out of the structured data that's within the healthcare system. And when you take this out into the community, patients are not just patients, they're people. Their data sits in multiple different silos, in social care, housing, justice system, ambulance service, etc. So enter OMOP. So we made an early decision. I won't go into too much detail about OMOP because I believe one of the themes for this particular session is around the tools rather than the use cases. So we started our OMOP journey about 2 years ago, and we've been fairly, we've had a very good experience, doing this, primarily because of the kind of tools that we use to do our OMOP mapping. And I won't go into the details of what OMOP itself is. This is our data lineage. When we started looking at how to do OMOP, we started where anyone doing OMOP would start with, things like the Odyssey Rabbit tools. Hey, here's your table. You just draw some lines to your target tables and it's done. It's not like that at all. And when you want to work as a team, the data engineering tools that you use become critically important. We used a tool called DBT, or Data Build Tool. Please do check it out if you're getting started, and if you're already either in cloud or on-prem and you're not planning to move and you have decided on your data technology, then DBT is a fantastic tool to use. It provides you data lineage. It's self-documenting. It automatically generates all of your metadata. and it allows you, within reason, it allows you to work as a team, but it does have limitations. And for an organization that comes from traditional SQL Server, Click or Power BI and stored procs, this was a paradigm shift for my change, for my team. We, I think, are still one of the very few centers in the world where our OMOP data refreshes every morning. But this morning, if I go and look at my measurement and observation tables, the data is current as of the midnight before. And we're trying to reduce that to kind of maybe every few hours. We're hoping to be able to do that. And for our efforts, we did win an award earlier in the year. We got the HGI UK Team of the Year award. We have close to 1 billion rows of data across all the tables for Lancs teaching hospitals. And we're going out to do exactly the same for University Hospitals of Morecambe Bay. And the data that we have in OMOP now feeds a clinical trials discovery platform called Trinitex as well. And the feedback has been that from Trinitex has been that we have one of the cleanest data sets in their global network. We presented our work at the Odyssey Collaborator Showcase last year. The way we've done it, rather than, people have been doing OMOP for about a decade, but the way we did it in terms of our approach and the tools we used has generated quite a bit of interest, to the point where now there's a DBT working group within the Global Odyssey community, and we've just contributed to converting the synthetic Cynthia to OMOP ETL process, and we have a DBT version of that as well. But more importantly, this picture here is my data engineer hiding behind the poster last year because she's camera shy, doesn't like speaking in public spaces. That's her today. She co-chaired a panel at the National UK Odyssey conference. It's been fantastic to see her growth. And we're using OMOP for monitoring sepsis patients. We're using this as Tim, who's also doing a PhD. We use our OMOP data these are near real-time use cases for chronic kidney disease detection. And we're working with Tier 1 staff, who I believe Richard has been up to visit last week, and he didn't tell me, to monitor antimicrobial prescribing practices across the entire organization. So we started doing all of this, and once again, because we're talking about tools and platform tools and data engineering tools, we started doing this initially with DBT, and once we've done Lancs teaching hospitals, at around the same time, we were building out our SDE platform, which is an Azure Databricks. So now you've got a lot of our code is in Transact SQL or T-SQL, and we have Spark now up on Databricks, and we were looking, DBT doesn't do transpilation very well. And when you start working as a team, it becomes very, very tricky because one person changing one model can cause downstream breakages. So we're now migrating to a tool called SQL Mesh. If anyone's doing large-scale data engineering, please check this out. This automatically transpile. It allows you to maintain a single code base and allows you to transpile, use a single code base to target multiple data architectures. So this is what we're doing to build out what we're calling the OMOP medallion architecture on Azure Databricks. We will have OMOP with a few extension columns and extension tables, but essentially bronze, silver, and gold. Silver is what we're using for operational direct care intelligence, like the CKD algorithm and sepsis. But gold is where the really high quality data that's research ready and pseudonymized comes into play. What we are hoping to do in the next 6 months is supplement this data with data from NLP, which is something I'm going to speak about shortly. So that's our data infrastructure. So we have OMOP, we have a whole pile of other structured data. It now sits in Azure Databricks. We have a single instance of a single lake house for the entire region. We have all the 5 providers connected up. We have 3 flowing data, and the 4th provider is going to start flowing data hopefully this month. And next year, we'll have primary care data in there as well. Alongside this, we have a trusted research environment. Our trusted research environment sits on Kubernetes, which allows us to spin up containerized isolated workspaces within seconds. We've had quite a bit of success with this approach. We've hosted a wide range of projects, including projects that require GPU. we're not like King's or UCLH. We don't have a high performance compute cluster, just sitting around. So we need to kind of be able to spin up these workspaces on demand and only pay when they're getting used. We're hoping to that this will be part of the DARE call, and we're collaborating with UCL, Turing, and Hig Dundee to build what we're calling the K-tree, Kubernetes native cluster research environment. And we presented some of this work at the recent Odyssey UK conference, looking at not only how researchers come in and use their data, but if you're a research software engineer, you want to have all of the tools in. If you're familiar with dev containers, almost exactly the same principle. If you're a research software engineer building platform tools, then you want to be able to come in, spin up a workspace, and start writing code without having to spend hours and hours setting up your machine to work. This avoids the, hey, it works on my machine, why does it not work in yours scenarios? Well, CogStack. So I've kind of known James Richard for about 3 years now, I think. We did some initial work with Medcat, and we're hoping to do this in anger in the next 6 months. Once again, doing all of the good stuff that people have already spoken about, but we don't have massive GPUs sitting around, and we have 5 hospitals to do. Just at Lancashire Teaching, we have 8 million clinic letters. God knows how many radiology reports we have, and we are on. We have some kind of bad financial break happening. There's vacancy control, recruitment freezes going on, so I can't go and buy GPU instances. So this is how we're going to do it. We did this 2 years ago. So we're planning to do this on our Kubernetes cluster. So we'll run Medcat and potentially other models on Kubernetes, but we'll run them on demand using something called CADA. We have a working prototype. First time, Tom, nearly done. I just seen it, so I'll take 1 more minute. That's okay. So we're going to use CADA to do this. And we're looking forward to working with Richard on the CDT, the Drive CDT team. We're getting 2 PhD students who are then going to start putting all of this together by making our data more discoverable to large language models and AI agentic workflows that operate on our OMOP data. These are a couple of screenshots. We also do computer vision research. Let me quickly skip that. We've been fairly successful in the past few years. Data is where the money is at. Or a consultant surgeon who started a digital journey and we've been reasonably successful in building a massive team around this. And we've secured quite a bit of funding from multiple organizations. And back to Richard, epic quests need epic people. So I'm super proud of the team that we've managed to build up in Lancashire, South Cumbria. But not only that, I'm very proud of the fact that we're able to collaborate up and down the country, and that people are beginning to recognize that we kind of know what we're doing, hopefully. And if you like what you've seen so far, then please Google SDCon. There's a link in the chat as well. And if you're up in the north, drop by. It's the entire event is in a nature reserve. This is in November, but we're hoping for some good weather. That's me. Thank you.
Thank you for this opportunity. My name is Srikanth, Valende Srikanth. I'm based in Melbourne, Australia. It's about 9 o'clock at the moment at night. But it's good to be here in this symposium. Thank you to Richard, Tom, for inviting myself and Richard Beer, who's my colleague, who's around, I think, on the call, to present at this symposium. So I'm a clinician. I'm a specialist geriatrician. I'm a dementia specialist. I'm also the director for the National Centre for Healthy Aging. And Richard and I have been working on this particular problem of using unstructured data to advance our knowledge about dementia. I have no disclosures. So the aim of what we set out to do, and this is what led us to collaborate with Richard at King's College and procure access to CogStack, was to develop NLP-based algorithms on routinely collected unstructured data, and then to be able to use that together with structured data that we have to reliably identify people with dementia when they access routine healthcare. And I guess the reason why we wanted to do this was it started out as a grant that we got to try and improve methods to estimate dementia prevalence in the community. We know that most estimates of dementia prevalence come from routinely collected structured data, and most of that comes from healthcare utilization. We know that many people living with dementia are not being counted in prevalence estimates, and the Australian government has made national dementia monitoring a fairly urgent and specific goal. We also know that when people come into hospitals, dementia is often under-recognized in routine clinical encounters, and that leaves them at risk of poor clinical care. We as clinicians are also not very good at recognizing, at recognizing dementia when we encounter people with the condition in routine clinical care. We might be good if we're fairly specialists if we're specialists in the field, but usually junior doctors, generalists find it hard to capture this. And the capture of dementia as a condition is mostly done after the fact by clinical coders who have to go through the records to see whether clinicians might have noted the presence of dementia. And that method is what leads to our usual sort of coding, the ICD coding that comes out. The method of that kind of method is pretty inaccurate when tested against a gold standard specialist diagnosis. It's like a toss of the coin, about 50 to 60% accurate, which is why we felt that NLP techniques on unstructured data carry some promise in overcoming this. So we really wanted to combine unstructured data or the capture of dementia with unstructured data and value add to our usual methods of capture using structured data. The scene where we did this, so the National Centre for Healthy Aging was set up with Commonwealth government support in Melbourne. It's located in the Frankston and Mornington Peninsula, which is a waterbound region. It's got a population of about 310,000 people. And our health service that we're affiliated to here, Peninsula Health, is the single regional public health service for that particular region. So we collect all the health data that comes through. We have a common UR number that links all these people. And hence, we've been able to create a platform which draws from the routine systems. There are about 13 disparate systems. We've created a clone of the systems and have curated the data and internally linked data within those systems for capture of various conditions. So we've got millions of episodes internally linked for over 10 years. We've got about over 1 million unique individuals within it. And we've also got standing linkages externally to federal and state datasets. We've created a core data spine comprising of about 131 core data items based on a Delphi process. These are structured data. But we've also then gone on to implement CogStack. This was back in about 2020, 2021, in collaboration with Richard and through Monash Partners. So that's allowed us to really pull together unstructured data within this data platform. We really wanted to bring together in this particular project the expertise of traditional biostatistics, which is often the way we look at structured data in this setting, and also data science, which obviously you guys are all familiar with and plays in the field of unstructured data. So really what we did was go through the whole system that we had and identified the kind of relevant variables for structured data that we would use to identify people with dementia. We had an expert panel which comprised of a health information specialist, comprised of expert neurologists, specialist geriatricians, and they organized these data into 3 tiers. The tier of variables that we should include, the ones that we should definitely exclude, and then another tier combined to produce a smaller predictor set. This is the structured data set. For unstructured data, we asked the same expert panel, what words or phrases would you expect to record when seeing a patient with dementia or diagnosing a patient with dementia? And so we had the 3 sets of people. You can see that the number of keywords or phrases that those 3 groups generated were different. Geriatricians seemed to generate a lot more phrases, and the examples of the EHR data that we saw, or those phrases in the EHR data that we saw, were these in number. These concepts really map to the domains of function, cognition, behavior, risk of falling, the therapies that we might use in dementia, such as cholinesterase inhibitors, the tests that we might commonly do to screen people with dementia, including imaging. We were able to capture episodes of behavior relating to confusion that we would often see in people with dementia and delirium, their sleep habits, and nutritional data as well. So we then had 2 elements of modeling. So we had a total sample of about 1,082 people. 362 of those had specialist confirmed dementia who we recruited through memory clinics, and 720 without dementia that we recruited from the community who had electronic health data in our systems, but they were screened out using a telephone interview. So in all, we had about 45,000 episodes of patient care. So we had 2 different data reduction and modeling streams. Both included input from the expert panels, particularly the identification of concepts were refined and selected by expert panel with regards to the NLP. In the structured data set, we went through the usual kind of approaches using logistic regression. We then penalized that using a lasso procedure. And in the NLP stream, we used a range of candidate models and approaches. And in the end, what we did was try to see what the combined model would do in capturing the presence of dementia. Just a little bit of the sample characteristics and the text data availability for our sample. When we used our structured data to compare the non-dementia group to those with dementia, we found that we were capturing the right kind of people in the dementia group. They were older, they were more likely to have dementia ICD codes recorded, more likely to be prescribed the disease medications for Alzheimer's disease, and more likely to be admitted to the kind of wards that you'd expect people with dementia to go to. With regards to text data availability, I think per person, the kind of median document count that we had in the dementia group was about 63, indicating that they were more likely to be hospitalized and have more records. And in the no dementia group, we had slightly less. For the community group, we had a similar number of records, document counts per person as compared with those with no dementia. Look, this table probably gives you the final kind of results that we have. These results are under review at the moment. Essentially, what we found was with the structured data stream, age only was only somewhat good, but when we used the lasso penalized model, the areas under the curve were reasonably good, 0.85, with fair sensitivity and specificity. When we use the NLP stream, you find that just a simple keyword search just doesn't cut the mustard, but the other kind of approaches, the modeling approaches, were fairly good, and we chose to take the random forest approach to combine with the lasso penalized approach. You'd see that the kind of AUCs for the 2 were fairly similar, but when you did combine them, the actual value jumped. So the AUC really jumped about 0.95 with quite high sensitivity and specificity. Really, that's telling us that there's a number of pieces of data that we're usually not capturing if we just look at structured data that we have access to. Combining those two approaches can be a really good way to identify people with dementia, a condition which is hard to capture. And so the next step that we're going towards is, apart from validating that in further cohorts, which we have access to, is to try and understand, well, if you do that in the end, how can you actually use that data apart from using it in prevalence studies? So we're trying to then move on to understanding what patients, the consumer, or their caregivers think about using these tools for flagging cognitive decline. What are the downstream sort of yeses and nos and pathways that we might construct? We're then looking at incorporating large language models into this process, and then applying a similar framework for identifying other conditions within our platform. For example, delirium, frailty, these are important alerts that have implications for clinical care. We think this has relevance, as other people have said, to a range of other conditions, efficiency gains in identifying target groups of trials, obviously, and potentially other new models of care, accuracy in clinical coding. And we're really pleased to be sort of working with the King's group to try and get ahead in these areas. Partnerships important for this. We've got our own local partners that we work with, but certainly our international partners, including King's, are important to us. Thank you. I'll just stop right there.
Thank you. Hi, everyone. I'm Zina. I'm a computer scientist. I'm a lecturer, senior lecturer now, in AI in medicine, King's College, London. I have two disclaimers before I start. Sorry, it's a microphone not working. Or is that too far? I tend to move a lot when I talk, so maybe. Is that better? Can you hear me? Yeah, good. So as I was saying, I've got two disclaimers. Number one is my work, unlike many of the presentations you saw today, builds on the layers of abstractions that lay on top of CogStack. So we have a great data harmonization system, and then we've got many applications that are developed on top of it. My work really is about making the technology better so that we can have better applications, and hopefully that will be clear when I start speaking. The second disclaimer is that I completely changed my talk 2 days ago after the announcement of the Nobel Prize, specifically one for chemistry. And I was lucky enough to be able to listen to one of the winners speak yesterday at a Drive Health event. And that has shaped a lot of my talk, as you will see. So the prize in question here is the Nobel Prize in Chemistry for AlphaFold. And I'm sure most of you know that AlphaFold is a AI model that aims to predict 3D protein structure from nucleotide sequences. And most people who don't really, who just vaguely know what AlphaFold is, I think it's just a deep neural network that's doing end-to-end work. Give it the sequences, it will output a 3D structure. But actually, if you take a slightly closer look at the work, I've highlighted the section here in the abstract. It's the highlighted section, so I need my glasses. So underpinning the latest version of AlphaFold is a novel machine learning approach that incorporates physical and biological knowledge about protein structure. Why is this sentence important? Do I switch slides? Yeah. Here's a kind of a description of the architecture of AlphaFold. I mean, it looks complicated, it is, but hopefully I'll try to simplify. This is just from their paper. No, I'm inventing anything. There are 3 modules, essentially. The input module basically does the QC and does multiple sequence alignments and gives you sequence representations of the nucleotides. And then after that, there is the custom built neural network. That is, kind of the biggest beast here. And it's a network that is designed to take the input from the previous module and gives you a representation. And if you know anything about neural networks, is that the representations they build is vector-based in the latent space, completely incompressible to the human beings. So that's the output of the neural network that they have, which is called Informatics. What I'm really interested in is the last module here. It's called the structure module. And that module takes the output of the evoformer and does something very, very spectacular, in my opinion. A lot of text here, but I just want you to pay attention to the IPA module here. That's a description of that module. And sorry, I think there's text. So what John Jumper was saying yesterday is that this module establishes a two-way conversation between a neural network and a constraint satisfaction system that enforces spatial and biological constraints on the output of the neural network. Meaning, every time the neural network outputs something, there is a domain expert that is checking what the neural network is outputting and correcting it, leading it to a better path. So it's just not a neural network doing everything on its own. There is an expert somewhere. And that expert, according to John Jumper yesterday, has led the AlphaFold to produce better output with much, much, much less data. And to me, that is quite important in what I do. Let's take that picture and contrast it to what we do in medical informatics and AI medicine. So before I actually move on, I just want to make another note that he made, which is AlphaFold does not work and will not have been there if we just took a transformer and plugged it into the data and expected the best. That would not have happened. First, the deep neural model, evoformer, is very custom built. Second, the evoformer does not work on its own. There's a lot of domain constraints, scientific knowledge that goes into the guiding the neural network into its output. So then I went home and I started thinking about, the latest development in what I do. So just to give you a bit of info, I am interested in predicting anything about a patient from their health records. Okay, I vaguely call it patient trajectory prediction, but I predict, well, the models I build, they're quite generic, and what we try to do is then we try to customize them based on what our collaborators want. But I can predict, deterioration, ICU admission, diagnoses, anything you like. Okay, and then I wanted to, a quick literature search of the latest development in deep learning in these models. And these are pictures of, the hottest papers that just came out. Okay, and the diagrams are quite complex, but if you just look at these diagrams, the emphasis is on, data cleaning up and structuring, which is what we do in CogStack, which is amazing, right? But then if you look at the AI, if you want to call it, it's exactly what John Jumper said not to do. Okay, it's a transformer plugged into the data to produce output, and it runs wild on its own, and we hope for the best. So I'm trying to do something a little bit different. Trying to do something that's domain informed and actually scientifically more plausible. So the question arises here is that I know many medics are here in the building. Medicine is a very knowledge-rich domain, right? Got lots and lots of data, but you're very knowledgeable people. So why aren't we using what we know? So what we're going to see next is my very little efforts, me and my team. Ling Long's right here. You want to raise your hand? He's an amazing computer scientist who tries to do to use this knowledge into improving diagnosis, prognosis, and deterioration prediction in general. So first of all, I'm going to take you to two cases. I think I only have one. We built some models to work on structured data, and then we just recently moved on to unstructured data. So I'll walk you through the structured data case. Well, what does structured data mean is think of it as labs and vitals. Things can be, for us, represented as a matrix. Okay, so this shows you patient signals progressing over time. And every sample, we think of it as a patient. result is many matrices for many patients. We call it multivariate time series. So the work I've been doing for about 4 years now is take the data from EHRs, put them into matrices, and then do some predictions. But there is kind of a hiccup there. There is an obstacle that we need to pass. Every neural network model, apart from generative models, expects good matrices, meaning matrices of kind of uniform rows and columns, and all the data should be there. The problem with electronic health records data is that they're produced as a byproduct of clinical care. Therefore, the numbers are ordered by clinicians' discretion or clinical workflow requirements, which means you don't get all the numbers at the same time, which means these matrices, they will have missing values, lots of them. And the missingness is not random. It is dictated by clinical practice. Okay, so now if I want to plug this into any deep learning model, I can't right away. I have to do something called imputation, kind of interpolate the data to guess the missing values and produce something that I can work with. So there are many clinical outcome predictions that work on structured data. I've had my fair share of playing with those, and these models, some of them focus on the imputation part, which is guessing the data and then making an output. Some of them just use simple imputation methodologies or use packages and then focus on the deep learning architecture that produces the output. So I was just following that stream of work until these very special people came into my life. My 2 PhD students, Ling Long's here. Hugh, I don't know if he's online. He's in Canada right now. And I've asked him for a picture that's less acrobatic, but he just sent it to me this morning. So, as I said, Ling Long is a computer scientist and Hugh is a doctor. So Ling Long started his PhD a few years ago, and he was trying to build on what I was doing, building clinical outcome prediction models. But he discovered that the performance was just horrible because of the missing data. And he started by using, the latest imputation models, deep learning imputation models to make these complete data sets better so that we can make better predictions. So, and then we were discussing, which is one of the team meetings, we were discussing how these deep learning imputation models work. And Ling Long was explaining to Hugh that, you have a matrix right here, and the time goes horizontally, and then you have features in the vertical space, and then you have missing data. Basically, the contribution of later points of a given feature to the past decreases with increasing time gaps. So the larger the time gaps, the less the future has an effect on the past. Then Hugh said, well, that doesn't make any sense. Because as a doctor, the heart rate that I took 2 minutes ago and respiratory rate half an hour ago and a lab test order this morning are equally valid. So we went about to embed this information in our imputation model. So don't worry about these equations. The first one is the status quo, which is that sigma, which is the gap in time between the last recording of a feature and the current recording of a feature and the last one. That's the length of the gap. The higher it is, the less the gamma, which is the contribution of the future to the past. That's what he disagreed with. So Ling Long went and made another function. What he did is that he got this tau, which is the median expected recording gap for a given feature, which is extracted directly from the data. And then we plugged it into the decay function. And the results were astonishing. Now, I don't want to underestimate the role of other things we did in this model, but as you can see here, imputation performance, which is mean absolute error, in our model, which is CSI, the last 2 rows, is much better than the status quo. Not only that, is that if you look at the columns, so we have 20%, so the masking ratio, which is the amount of data that we reserve for testing, the ground truth, as it increases, the higher the difference between CSI and the status quo increases. Why is that important? Is because the more testing data you have, the more likely you are to encounter issues with the model. Same thing with classification performance. I know I don't have time to talk about the unstructured case, so I'll leave it, but I just wanted to tell you this story about the importance of collaboration. I'm going to skip all of that. So if you, I don't want you to undermine the importance of medical guidelines, evidence-based medicine, and all these things that can make these models better. The key is collaboration, and I'm very happy to talk if you have insight that you want to put into our models. Thank you so much.
So who wants to kick us off question-wise? We, I believe, still have presenters online as well.
Speaking as a patient, when will I be able to chat with my digital twin that knows my digital records? It's not full, it is my data.
Who wants to take that? Yeah, I guess I can start with when will I be able to chat with the data? I was at Coventry and Warwickshire Partnership Trust on Tuesday, and one of the psychiatrists there actually said, why can't I just use an LLM to be able to chat with a record to find data around a patient I'm trying to take care of? These are really complex patients that have potentially been in care for years, definitely months, and the answer is soon, hopefully. There's a whole, hopefully this session has had some motivation around and try to clarify why data is so difficult to actually just provide it back to the patient firstly, but also back to the clinicians that is trying to take care of the patient within their own setting. So all clinicians in the room, they probably encountered cows, computers on wheels, the fact that you can't even log into them. They run really old versions of Windows, all that kind of stuff. That's very, very basic that we need to solve, hopefully through the budget in a couple of weeks. Maybe don't hold your breath, but still, once you've solved kind of core infrastructure issues of actually getting technology available to clinicians to be able to access the data, moving the data and surfacing it to patients ultimately is where really want to get to. I think it's definitely initiatives going on right now around having data, putting data back into the hands of patients so they can, instead of repeating themselves, they can just hand something over to some sort of digital key maybe to a clinician to say, yes, we can then download your records because you have it with you. Those kind of initiatives, again, they're going to rely on standards, they're going to rely on adoption. There's a transformation piece as well to be said. I think Vishnu.
I'm just going to say, Tom, that we can already chat with our data, right? I know I skimmed through that very, very quickly, but we can, have large language models interacting with OMOP, for instance. So we're not far off. Well, it's an active area of research. We're not too far off, hopefully, for at least some initial prototypes that will start emerging. I know there's plenty of work that summarizes patient records into discharge summaries. I know you guys are working on it as well. So hopefully not far off. Unless, of course, large language models prove to be a dead end in AI research.
Yeah, so I think Fish is right. We're not far off. It's going to be mixed, as always. There's still hospital trusts right now, GPs, maybe less so GPs, definitely trusts that's still on pen and paper. Obviously, getting over that hurdle of pen and paper and storing it in a filing cabinet somewhere is the very, very first step. Having machines that work is the first step. Vishnu's streets ahead a lot of other trusts, but in his space, yeah, soon, which is pretty exciting. Thank you, Antonio.
Years and years to navigate the information governance and concerns by politicians and political leaders about sharing data. So right now, for example, we have data secondary care, but it's really hard to get primary care. It's impossible to get genomics equivalent data, merge it all together. And the concern is patients will be upset or are concerned or we haven't reassured them of. The question back is, do patients really worry about this, or they just expected that all this could go in one big national data lake where all bits of data will be available to all of us?
I can cheat a little bit here because, as well as being a patient, I'm an IT professional. And I certainly don't. I certainly don't think that a data lake is the correct implementation. As an IT professional, I believe the correct implementation is massively distributed databases, which are called blockchains, which many people here at least have heard of. That's the correct and the technical solution to the challenge, definitely not a data lake. But speaking as a patient, there was a massive delusion of adequacy in the NHS as a brand, and in professions generally, unprecedentedly buying a house, and the process is pathetically inadequate. I'm a hard scientist with a physics background, working in IT. You know, if we built aeroplanes the way that we run the NHS or the conveyancing of a house, we'd be dying every time we flew everywhere. So when the underperformance is so catastrophic, today I learned, for example, that my consultant, not her personally, may have statistically forgotten to forward my MRI request. Yeah, you did that when you were flying aeroplanes. You forgot to check whether the doors would go fall off. There would be complaints, wouldn't there? That would actually be acceptable in the industry. So when I talk about making medical records available to the patients, I'm talking about empowering the patients to actually get the service they demand from professionals, and in fact means they to and pay for. That's the end of my little speech. Thank you very much for listening. And the question is great for your heart. And I want to thank Alan, who's the patient representative person here, who invited me along.
Yeah, thanks so much. We've got time, I believe, for one more quick question. Otherwise, I won't keep you to coffee and pastry. One question. Please shoot. I can just repeat the question. It's fine. Go for it.
Data. So what I mean by that is, for example, let's say I have a medical record, then I use, let's say, a locally run AI model on my smartphone to remix my personal data, which can then be used to train AI model for certain health tech. But then I'm part of the equation when it comes to royalty, because I'm saying my health data is IP. And to what you mentioned about blockchain, there's, for example, a level 1 blockchain called Searle protocol. And that's what I'm kind of alluding to. So if I was to kind of take an eagle view of what's happening so far, so CogStack has been using NHS data for nearly 9 years, which is amazing. So we've got all transformer. Then if I was to be the devil advocate, how about all the patients that contributed to the data, so that now CogStack is kind of spinning out this company? Is a patient being rewarded for providing the data to the NHS? But you don't answer the question.
Yeah, just a comment. Maybe we can pick it up after the session. I think there's definitely something to be said around. It's the reason why we spun out and are owned by 4 NHS trusts and 2 universities. From a GDPR perspective, the data controller is the trust. Obviously, it's your health data, but it's paid for and stored and managed by those trusts for the betterment of patients. So we can definitely take this into the coffee session, but I think that's the reason why it's really, really important that we are co-owned by the trusts themselves, who are there, in existence to take care of patients ultimately.